So welcome to 2025, the Canadian Primary Care Research Network Learning Series. And we have a bunch of different learning sessions that are lined up this year. And we're really excited about all the different speakers and people who will come and help us to learn. So the idea about the learning series is really to learn and basically have a dialogue about learning that we can be doing within CPCRN to strengthen primary care for all Canadians. And so this first series is around integration of care, and our first guest will be talking about integrating informal care through empowering people's informal networks to achieve better population health. And I should remember that if you would like to provide a land acknowledgement of where you are, please do so in the chat. I will say that I am grateful to be sitting and living and playing on the unceded territory of the Coast Salish people in Vancouver, British Columbia, and that I have been learning about how important the cedar trees are here. And I have a couple cedar trees and oak trees as well that have stood for over 100 years, so older than the house that I am currently sitting in. Okay, so back to this session. Again, it's integrating informal care through empowering people's informal networks to achieve better population health. And the objectives of this session are: one, to identify potential opportunities and benefits of integrating informal care into primary care, and two, to identify elements of integrated informal care programs that work at multiple levels for high impact. And our guests today are Dr. Michelle Howard. She's an associate professor in the Department of Family Medicine at McMaster University. Deborah Sattler, she's a founding partner of Health and Wellness Friendly Community Action Learning Lab, and also an advisor of Compassionate Communities, Hospice and Palliative Care Ontario. And then Chris Elliott, who is a community volunteer for Health and Wellness Friendly Community Action Lab. And with that, I will turn it over to the team.
Thanks, Sabrina. I'm just going to get up the slides here. Sorry, I should have put them at the first one to start. Let's be a second. Okay, is that looking all right?
Yep. Yes.
Great.
All good.
Thanks. Okay, thanks for the introduction and the opportunity. I'm coming to you from Hamilton, which is the traditional territories of the Anishinaabe and Haudenosaunee people. So yes, our topic or our title today is integrating informal care through empowering people's informal networks to achieve better population health. I'm kind of a written person with some notes as well, so if you see me looking down a bit, I'm just making sure I'm staying on track. So just before we get started, just want to just declare that some of our presentation is based on a research grant that we received through a CHR competition, but was funded directly by the Ontario Ministry of Health. So the views expressed are the views of ours and do not necessarily reflect those of the province of Ontario. So I won't spend too much time on the objectives as Sabrina went over them, but over the next few slides, I'll just give you a bit of an outline of what we're going to share with you. I'll be describing some background about our work. And first, I'll introduce a concept that we call people-integrated care, and what we mean by this and why it's relevant to primary care and population health. And I'll describe at a high level some of the research and evaluation we've done on this issue to this point. And then Deborah's going to present a bigger picture perspective of how this people-integrated care system might scale up for impacts across multiple levels, and how a public health approach that we're proposing could benefit the environment in which primary care works, so that we're all moving in the same direction towards good population health and well-being. And Chris is going to then share some personal experiences with the approaches that we're talking about today. So just to let you know a bit of background about who we are and our kind of virtual lab. So we are called the Health and Wellness Friendly Communities Lab, and we're a voluntary consortium of academics, policy developers, and practitioners who came together several years ago to think about population health from the lens of shifting culture and increasing social capital in communities. And some of our original inspiration came from the compassionate communities movement that arose from palliative care. Our secretariat is, over the years, we've kind of developed and wanted to have a virtual presence as a lab and document all of our work and have a place to share our knowledge. So we've got a secretariat through the University of Toronto, Leslie Dan Faculty of Pharmacy, through the support of one of our original founding members and colleagues, Dr. Lisa Dolovich there at U of T. And here's our contact information, but of course, with the slides being uploaded, you can always take a look later if you want to get in touch. So today we're going to share two main areas of our work. So first is our work on visioning a system that we've called people-integrated care and determining how best to influence action towards this. And the second area is the development of tools, training, resources, and education for supporting informal care, which is I'm going to describe in the yellow area of this diagram. So this diagram is depicting how different aspects of health intersect and are related to overall well-being in the center of the diagram. So we know that informal care is predominant in people's lives, and it contributes to all aspects of health and well-being. So the care that comes from our informal care networks is social, emotional, practical supports and things like that. So of course, formal care, medical care also provides a major role in our health, but overall, throughout our life course and in the population, it's only a small component of what contributes to our overall well-being. Probably not a big surprise to this audience, but this figure also shows that informal care occurs in multiple networks, so it's not just one thing, but it occurs across multiple networks. So it could be, of course, immediate family, friends, personal network. And then there's informal supports in communities. And then there's also neighborhood, churches, schools, etc. So it's all the rest of the community that's outside healthcare. Social health in particular is important in the context of this informal care network. Social health is very important to our overall health. People that lack social connection and supports, generally, if they are living with an illness or disability, they tend to have worse outcomes. This contributes to potentially unnecessary use of high use of healthcare resources, and often for reasons that could be prevented and managed in the community. So while there are many initiatives being added to formal healthcare to address social issues, we have noticed through our research and our literature review and studying of models that there's not a whole lot of attention given to leveraging systematically the informal care networks, which is kind of an untapped resource. So these efforts, and there is evidence that will point to these efforts to actually systematically leverage our informal networks can add value to healthcare systems. Some of our earlier pilot research in testing some of these methods and tools told us that people actually didn't initially recognize how important their social health and risks could be to their overall health, and how important it is to not become isolated, and they were glad to have this education. And they also benefit from help to intentionally think about their own informal care networks in relation to their own goals for well-being and quality of life. So that's why our second area has been creating the tools, training, and resources for education and support of informal care. And this also triggers people not only to receive care, but to reach out and offer care to others. So rather than thinking of population health in terms of a scarcity of resources, we're thinking of it in terms of there being lots of resources out there that can be better mobilized to address people's desire to give back and be part of their communities as well. So just a very high level overview of where we've got, how we've come to this stage 5 that we're kind of at now in our research approaches that are underpinning our proposed population health model and how we like to communicate it. So our work's been focused throughout on contextualizing evidence of gaps and opportunities in the informal care area and identifying strategies that are informed by evidence to tailor these strategies and test and evaluate them. So we examined literature relating to defining and describing our challenge area, such as the evidence for benefits of informal care and social care and the consequences of not addressing those needs on public health services. We examined literature from the lens of how informal care networks driven by people's desire to give and receive care can add value to those existing health services and change culture in communities. Second, to inform strategies that would be helpful to implement envisioned system level solution, we reviewed and analyzed a bunch of exemplar programs that use various approaches to leverage informal care. So none of them were the people integrated care system we're talking about, but they had elements of it through systematically leveraging informal care. So we looked at some of the key features that would need to go into a future system. Number 3, to contextualize systems and organizations who would have a role in implementation. We've been conducting stakeholder dialogues to tailor our messages to more clearly convey the benefits here and build partnerships for testing tools and resources in a variety of new settings. Synthesizing knowledge, doing all of this is what really helped us come up with the people integrated care system. So we mapped out a framework for depicting this system along with by using the practical strategies for implementation from that analysis of the programs. And now at step 5, we have some academic papers in the works, a policy library that's going to be online of documents that can describe various aspects of how we arrived here, and other resources as communication tools for various audiences. So in relation to primary care, of course, why we're here today, we know that primary care is itself a population health strategy. And the concerns are that there's more pressure being placed on primary care and other formal services to deal with the many care needs of individuals which are outside their scope sometimes, but are within the scope of the community to address. So literature clearly identifies that people need a wide range of supports for prevention, wellness, mental health, self-care, and peer support to cope with their health conditions and disability, as most of that they're living with in their communities. One example of the types of supports is from a well-cited scoping review that the gaps related to health and wellness of concern to most older people with chronic conditions and disability are social relationships, psychological support, and those practical activities. So we're really proposing a system to tap into informal care with existing capacity in the communities without burdening practices in the healthcare system. Such a change, if it was to become a community-wide system, could actually change the environment that primary care works in, could alleviate some of these stresses and have everyone playing to their strengths and doing the type of care that they're most equipped to do. So we are trying to, versus not add on services, but extend everyone's capacity so that they're doing work towards this end. So this diagram is just another way to show how much and who's in this, in our informal day-to-day care networks and lives. So for the we're trying to contextualize this for primary care. So knowing that most of the population, most of the time at any given moment is healthy and not accessing health care. So most of the care that people receive, need, want, and give in day-to-day life is informal. And the mechanism for this is the emotional support and all of those other supports that were just mentioned. So the people integrated care framework is not an add-on to the overburdened healthcare system. It's to address these missing pieces in a much more systematic way. So building an informal system of helping, informing, and educating people on services and how to self-navigate to these supports. So rather than relying on formal services to do this navigation, this is what our lab has been working on to educate, create the tools and education for people to learn to self-navigate. This is also, if people don't have to go through formal services, a lot of people don't have a family doctor currently. These are things that can be available to people, so it increases equity as well if we take a more upstream preventive public health approach and take things out of the formal system into communities. So what we have to address these issues, some of those tools that I was mentioning are what we have been working on. So we have the tools to make this happen. There are tools for various sectors, and that could be applicable to primary care as well. And we'd love your feedback on this going forward and opportunities to think about collaboration. But Deborah will talk about this some more. But just starting over on the left here, we have developed a social health screener. So this is a really key thing for identifying those needs that can be answered by your informal care network. So there's a short survey patients or people can do on their own. It can be done in a clinical setting. It can be done in any setting, and it's also available just freely online for people to try and look at. And that in itself has triggered people to actually start reflecting on what their goals for their social health might be, if they have any gaps in their well-being they'd like to address. For some folks, they will want a little bit additional help. So if there are risks, they can get some additional education from our navigators who are currently trained volunteers. And these tools and training can also be given to organizations or other services if they wanted to start integrating this. The third is people having, that's the community circle. So people having more of a navigation approach. For some people that might need that. This can be done by actual formal care teams as well. And teams can be trained on this. And we also have a mechanism to provide reports about the people in the care teams, aggregate reports based on people's self-reported outcomes that are through the tools that they're completing anyway that help them reflect on their goals and what they'd like to accomplish. So that data can be aggregated and given back to various groups that are using the tools for their population. So the picture on the right is just showing how within the whole system, these things can plug in to kind of maximize people's self-care navigation and informal care networks. We've also given a lot of thought to a risk segmented approach. So starting at the bottom of the pyramid, the focus for most of the population is who are healthy and fairly well, is on education and independent navigation, which would be where most people are in primary care. And then that personalized support from a volunteer that I mentioned is kind of moving up the pyramid, which is needed by fewer individuals. So in a practice, for example, that how this might work in a practice that's already kind of addressing social risk, maybe through social prescribing, is these tools could be easily built in, and community support agencies or organizations that are partnering on social prescribing, like Red Cross, could also incorporate these and fill some of that role. So we've been trying to tailor and think about things through the development to reduce barriers and increase equity of access to this approach. So this slide actually has links to that social health screener and the sign up for that next stage of after personal navigation support. We can put these up again in the end because we don't have a lot of time to stop for now on them, and they'll of course be in the slideshow that's posted online if people would like to see them again. So some of our other research and evaluation that's been done has shown some potential or some actual benefits in care experience and population health, equity, and signals that there could be better value achieved in population health through this model. So from 2017 to 2020, we were developing pilot programs, and the actual implementation started in Windsor, Essex, area of Ontario, southwestern Ontario, and it was called the Windsor-Essex Compassion Care Community, or WEC, as we call it for short. And over that time, through various iterations, there were over 2,000 participants and engaged and hundreds of volunteers. So in evaluating that effort, we have a paper published on the program evaluation and some other reports that participants showed high satisfaction with the program and on those tools, and significant changes in their self-rated measures of health and wellness and behaviors and social support and things like that, and also some reductions in self-reported emergency department use and hospitalization. In another paper, what was focused a little bit higher up on that pyramid on some vulnerable populations in Windsor, suggested that this model can act as a safety net for people experiencing vulnerabilities related to social determinants of health, and that there is some impact empowering people to act on improving their own health. And then because of those impacts shown on healthcare utilization, that's a signal that in comparison to another model where this was modeled from in the town of Frome, United Kingdom or England, was called the model of enhanced primary care, that was really influential in developing our model, where the primary care practice in the town, which covered the whole town, partnered with community resources and citizen volunteers, and eventually the responsibility for this was taken over by the community, and that's kind of how it lives on. But they demonstrated a 20% reduction in emergency department healthcare costs within that community, not just in participants, but community-wide within 5 years. So few, if there aren't many other than this initiative that we're aware of that have been able to show this sort of population level impact, but there is some evidence definitely that this model can have those impacts. So informal care supporting actual health outcomes. And just one other high-level timeline overview. As I mentioned, in 2017 to 2020, around those years was kind of the development, pilot testing, revision, and learning on how to test these concepts, how to measure them, and the community co-development. In the last few years, we've been continue to operationalize the people integrated care idea by identifying those critical features, talking to different sectors to understand how to customize tools and approaches, and looking for opportunities to test the models in different sectors to provide real world evidence. And then going forward, we're continuing to do that, and speaking with different sectors and trying to build like smaller case studies in different sectors and environments to get the real world evidence of what works in what situations and how to tailor things to different environments. And then onward with thinking about the policy, governance, funding, and who should own this is kind of some of the work we've been thinking about as well. How do we spread and scale, and where does it get a home within where things already have policy undertaken. So but those are, yes. So I'm going to turn it over to Deborah now.
Yeah, thank you. So I'm just going to offer in a few brief slides the policy perspective of how this model can be incorporated into system level change strategies to better support population health. So in addition to the patient level needs that Michelle has spoken to, it's clear that health systems across Canada are struggling with a wide range of systemic issues. Next slide. So we've actually kind of represented how our people integrated care model can work alongside existing transformation efforts underway in primary care systems in Canada. We really see this as a complementary effort to support system initiatives by leveraging that social and human capital in communities to achieve shared population health outcomes and better value. Informal networks of preventative and supportive care can be mobilized around people and across communities to bolster health services, to promote health, happiness, and connection at all stages across the life course. Next slide. Through our theory, research, and modeling, we have identified a number of important structures, processes, and frameworks for system-level implementation, as well as costing and cost-benefit considerations. At scale, both formal and informal care efforts combine to increase quality of life and optimize healthcare expenditures at population levels, with people becoming more comfortable asking for the help they really need and addressing the issues of most importance to them, as well as more comfortable in offering help and support to others, with communities also mobilizing to create new resources and support systems to respond to those needs and opportunities. And the visualization of those requests, those triggers, become that driver that promotes that economic value that we saw in communities like Broome. So the upside is that potential for improved quality of life for all patients, but also that potential to reduce the per average healthcare costs for those recipients of care by being more preventative, more focused on wellness, and offering that wide range of day-to-day practical supports that people are looking for that really promote their health. The next slide. To support the growth of this type of integrated community care system for the future, we suggest that there's at least three critical building blocks or catalyst actions that are beneficial right now. So the first is making people and systems aware of the importance of informal care to health. We go further through our tools by also trying to visualize those informal care networks that surround people and the ones that operate across community systems, because we believe that this transparency is really useful for more immediately recognizing gaps in care and motivating different types of strategies to address those gaps. Next slide. The second building block or catalyst action is to measure and make transparent social, mental, physical, health, well-being outcomes, experiences, and that combination of informal and formal care resources per year of care, as well as change in those measures over time for individuals, organizations, and populations. This builds a learning system approach that supports community development and prompts greater levels of accountability for real quality of life outcomes at societal levels. Next slide. The third building block or catalyst action is to recognize and value and support the wide range of both person and community-directed efforts that complement and reinforce primary care efforts in improving people's health. So Michelle has mentioned a number of them: neighbors helping neighbors, vulnerable persons outreach, education directly available to people to help them help themselves through self-care and peer support, moving towards goal-directed care, innovation, and using feedback for quality improvement. Next slide. The societal impact is significant, so we believe that this is a relatively low-cost, low-risk approach with significant public value upside. So, again, at population level scale, which wouldn't be achieved for some time, but with that risk segmented approach, we think it's feasible to offer all of those levels of support for around $50 per person per year, with the upside of better population health, reduced disease burden, delay in terms of premature mortality, all of the risks that loneliness, isolation, low life satisfaction generate in terms of those mortality and morbidity outcomes. Again, like Froome, that potential to reduce health system spending and optimize it to free up that capacity to direct that spending on higher priority initiatives within the formal care system and building more resilient, stronger, better connected communities. Next slide. Now, if you're interested in being part of making this change happen, there's a number of things we think that you could do right now within your own kind of roles and levels of influence in the system and in your communities, and as patients of primary care yourself and as caregivers for others. So we think there's an opportunity for primary care leadership. We'd love to work with more of you in terms of looking at your views and your ideas about opportunities, barriers, how it could be integrated into the practices and programs that you're already supporting, to advocate for the type of policy and investment and accountability that would build capacity for informal care and help spread ideas and help us with knowledge translation. In the really short term at that patient level, like we have these tools available, you could let people know about them and they could access supports through us. In the medium term at that organizational level, we see opportunities to embed some of these social risk or quality of life risk screening tools into intake and screening practices, and to coordinate referrals to community programs with those volunteers that can help people identify resources and self-navigate. In the longer term, we think there's opportunities for developing those broader health system frameworks that include support for these type of approaches and really operate at both upstream, midstream, and downstream levels to really tackle social determinants and population health. At this point, we're going to turn it over to Chris, who's going to offer us kind of some of that patient level, caregiver level, community volunteer level perspective on the benefits of this in people's day-to-day community lives. So Chris?
Hello, everybody. Obviously, my name is Chris Elliott. I'm a caregiver for two aging and seriously ill parents, partner to a girlfriend with serious health issues, and a healthcare consumer myself, and a community activist and current volunteer with the Health and Wellness Friendly Community Action Learning Lab. I've had 4 years of experience, a significant benefit of strengthening informal care and community support in all of those roles. I started my involvement with the Health and Wellness Friendly Communities as a student intern as part of a social service worker gerontology program. During my internship, I was part of the Windsor Essex Compassion Care Community Flagship Pilot. I was able to make a significant difference in the lives of many highly vulnerable people, such as securing donations for an electric wheelchair for a family in need of help. I was also able to introduce my mother, who is dealing with a very stressful and isolating situation trying to care for my ill father, as well as her own significant health issues, to the Health and Wellness Friendly Communities virtual Jamming for Wellness program, which led her to make much needed new social connections and friends, has helped her feel a little less isolated and lowered her stress level a little bit dealing with all of this. Sorry about the phone going off in my background. All right. In my own life, hang on. Let that finish, sorry. I don't know if you guys can hear that or not. Sorry about that. Right. In my own life, I have learned important information about social risks to health, how to promote my overall health and happiness, and have used my Health and Wellness Friendly Communities screening and action planning tools to my own benefit. I sincerely believe that this is a critical aspect of preventative care. I have been able to advocate for extra needed support for my family members and people close to me. For example, my quality life program, which 2 members of my family participated in and had positive results. They were provided with information, advice, and possible solutions for improving different aspects of living a healthy and inclusive life, such as stress, depression, and mental health. Especially helpful was the process to walk them through identifying person-directed goals, prioritizing issues, and finding resources and planning the action steps they were willing to take. I see the benefits in my own community of Windsor in terms of more opportunities for connecting and belonging. Group programs such as the Jamming for Wellness music program and the Persian Connection Cafe have spawned social groups outside of the programs themselves, giving the participants opportunities to connect with each other or connect with others who have similar interests, backgrounds, and ethnicities, etc. The Persian Connection Cafe participants have created their own separate social media group and expanded their connections with each other beyond the program itself into international partners and friendships and beyond. I host the Jamming for Wellness music program and have had the honor of meeting wonderful members of the community, some of whom reside outside of Canada. Through this program, myself and the participants living locally have been meeting monthly for lunch, We gather at a local nonprofit restaurant that helps provide employment opportunities for those who need help getting jobs in the community, thus allowing us not only to socialize with each other, but to help the community at the same time, which is another one of the nice points of being able to provide informal care, is that it comes from almost anywhere. And then one of the biggest advantages of the health and wellness friendly communities for me personally is being able to learn from different perspectives and adjust some of my priorities to maximize the care I can provide for others. I'm currently a caregiver and power of attorney for my 2 ill parents, one of whom is now in long-term care. Without the support I've received from the health and wellness friendly communities, both formally through their programs and information, and informally through the relationships I've gained within and without outside the program, I don't think I would have the courage and strength to keep giving my best to those I love and care for. And I'd like to make one final example, if I may, is my father is now in long-term care and receiving the formal care and everything else. But I find with family members or myself, I'd like to go up there and watch a hockey game with them or a football game with them or a movie. And I find that on top of the care he's getting there, it seems to improve his feelings for the day. Even after I leave, some of the workers say he seems to be in a much better mood. And just, that's just my last example of how integrating the informal care can certainly complement the formal care. Thank you.
Thanks very much, Chris. So that's, I think, really the end of our information we wanted to share with you. And there's a few potential discussion questions here. So we could open for discussion. Or Deborah, did you have anything else to add? Or Chris? Okay. Should I stop? I don't know. We could maybe put the questions in the chat or something. But if we should we stop sharing?
Yeah, maybe put it in the chat, and then I think Michelle had a question as well. But Michelle, do you want to talk?
So I just put a question in the chat about how this matches up to the CLSC model that they have in Quebec. My gut reaction to this is that any system that relies on informal caregiving, which has been the case in Quebec, has been, at least the way they implemented it here, it's been problematic. There's been so much informal caregiver burnout. That the second that informal caregivers are then written into the system, it almost gives governments and ministries of health an excuse to dump onto these groups that are not properly compensated or given relief. I know from experience, unfortunately, my mother has Alzheimer's disease. I was caring for her, and the CLSCs are supposed to provide a lot of what you showed, but in the end, the resources that they end up having are, diminishing and diminishing, such that it ends up that it's the families who really bear the brunt of a lot of it. Now, I'm not saying that this is necessarily what would happen, but I don't know. I just think perhaps you should just bear in mind some other provinces' experiences with some of this. Thanks.
I can comment that on that a little bit. I don't think we looked directly at CLC, so that's an interesting kind of comment, and we certainly will. We know that that happens, and that's actually kind of why we're focusing on this community-based system, because the system, whether it's formally like in Quebec or just kind of across the board, relies on those family caregivers and expects an awful lot of care and support for them, exactly as you say, without necessarily any tools, support, compensation from that role. We think that focusing on the caregiving experience, trying to improve it, but also building those community networks and also focusing on those individuals that don't have those family caregivers, again, from that equity perspective, and building up, again, leveraging people's desire and willingness to give back to their communities and be part of that volunteer force like happens in compassionate communities around the world. That's part of the solution to the caregiver burnout experience that you're just describing. And it helps optimize caregivers and support them in doing the work that they want to do without creating that level of distress and burden that so many of them feel. So we do feel that it's a really important issue, and that's why there has to be a whole system in place. And that's also why we considered this part of a parallel strategy, not writing them into your primary care system, but having that support operate alongside what the formal care does, for exactly the reason that you are talking about, that we don't want, just kind of that handoff that somebody else is going to take responsibility for it. We want all aspects of the system working together to support the people who need the help the most.
That's the way it's supposed to work.
Yeah. And it doesn't, and that's why we need a lot of rethinking about how to make it work like it's supposed to.
Michelle, any comments?
Yeah,
Michelle?
Michelle, yeah. Yeah, I'd just reiterate what Deborah was saying, like that system and the culture change in the community would need to be there. So that's but good to keep in mind that there could be unintended consequences that need attention along the way until that is built. So yeah, I could definitely understand how that could happen with adding too much to the informal caregivers.
That's also why we are conscious about using the language of people, not patients. And again, like we consider all of us kind of patients, but we think that that caregiving experience as a personal experience is worthy of support in the same way about goals, finding helpful resources, coping, finding other resources for practical support. So it's not just always that dependent person or that care recipient or that person managing the disease that needs the support. It's also the support networks around them.
That's great. And I think, Gloria, you had a question around patient voices. But I'm just wondering, Gloria, if after having listened to the presentation, you have any additional questions?
Well, not additional, but, oh shoot, my camera's in the wrong place. Not additional questions, but in Alberta, for example, each of these research pieces that are done, such as presented today, actually had patient voices right from the beginning. And what we discovered in that process is that it didn't change the need for the research because the patients were focused on outcomes. It focused more intentionally on the kind of words used to get there. So I just wondered if there was any comparison with today's presentation in that regard.
Do you have examples, Deborah, of like I know that with the way has been developed all along has been with various groups involving patients.
Yeah, we consider this a big co-design strategy. So we've gone the route, rather than having kind of a single identified patient representative, that the whole system, each of the tools that we use, is informed by conversations with direct recipients, and their feedback is used to both design and improve and figure out how to implement the tool. And every person we touch, we have a process to create an impact story around their experience to really understand what they were looking for, what their goals were, what kind of support they received, and how helpful it was to them in terms of the outcome. So basically, every part of this we feel is really informed by that patient, that user experience, as well as then the implementing organizations who might be supporting use of that tool with people, as well as, again, kind of at that system level. So all of those perspectives are really important. But your point about grounding it in people's kind of real experiences, real needs, real language, what they want, that's been critically important to us since day one.
Perfect. And I guess the importance of my question is so that the whole room hears the fact that you worked with the co-design attitude. It's a term that Alberta is familiar with, and maybe the rest of the country needs to have that same. So thank you.
Well, in each step, even at this kind of knowledge translation policy stage, we still consider it co-design, and even comments from the room like yours will be using to, you know, kind of make sure that what we're saying and how we communicate it resonates with, you know, people like you as well as our actual users.
So can you just talk a little bit about how you see this could be integrated better with primary care and how we might take steps together to do that?
Do you want to respond to that, Michelle?
Yeah, I guess some of the things that were in the action steps, and we're definitely looking for more input on that question as well. But some of the things that have been proposed, so it could be anything from using the social screener tool, incorporating that, like some sectors are looking now into incorporating that sort of tool into any current suite of things that they're using with their patient populations. It depends where a primary care practice might be at, but if they are kind of participating in social prescribing or something like that, then these tools could be incorporated to help make that most successful. Yeah, and other examples. Well, the big example that we based a lot of this thinking on was the role of the primary care voice and leadership, I think, in kind of advocating for this sort of model. And in that one community we mentioned in the UK that really launched it, and then they were kind of able to, it became owned by the community. So I know some of those efforts are underway, but just having the voice and leadership there too. Did you want to say something, Chris?
Yes, if I may, just kind of touch on Gloria's point. As far as like the patient point of view in that area, myself, since I've been working with, well, originally WEC, but health and wellness friendly communities, my friends and family who were, you know, they weren't doing so well. They were kind of socially isolated. My mom, especially, as the example I mentioned earlier. And I just kind of tried to take pieces of the programs available through this network, and then just kind of implement it to what let me say, most reasonable people would think of to help their members. Like, for example, kind of supplementing my dad's help by going and spending time with him socially, watching movies and that. And I also think, as far as my quality life program and touching on different ways of looking at your personal care and or the caregiving for others, I think part of the patient thing is becoming aware of what you have to do, and then knowing that there's informal ways to take care of it that can supplement the formal ways. And I think you only get that through this kind of I don't know, like a cooperative effort like this. And I think it's to try and pin it down to one patient's perspective or the other. I think it's kind of missing the point. It's just got to be almost like in time, played by ear as you go, and adjust your priorities to it, keeping in mind the formal system is only set up for that. And as you mentioned earlier, you don't want everything being piled onto the caregivers. But there's got to be somewhere in the middle to meet, and I think that's what this program kind of helps you find.
That's great. Thank you.
There's also in that part of the pyramid where it's people that are at slightly higher risk, where they are dealing with something, and that I think that's where it really comes to light. These kind of needs come up in primary care, and we've heard lots of family doctors and others say, like, yes, we see these kind of needs in our practice, but it's difficult, not always possible or immediately obvious what they can be doing, but through those reports that people are doing through the program, like Chris has described, how those personalized reports can help people identify what they want to focus on and their priorities. Like that can be shared within primary care somehow. Important for through other projects that our group has been involved with, like Health Tapestry. Like it's very positive feedback from the primary care team, interprofessional team, or family physician alone, to know what is really priority for the person's well-being, because they are trying to address the whole person. Yeah, so it's aiding that. It could aid that whole person care as well. And the kind of efforts that, if the family doctor or the interprofessional primary care team knows that the person's getting support for some of these things elsewhere, and they start to become familiar with what's available in the community. I don't think any family doctor has time to make a list of compile all those things. So if these circles and networks start to become more visible and apparent in communities where family doctors are situated and already know some of the resources, so if there's even more resources they could become aware of, and more knowledge for them of the patient's priorities and what's really impacting the ability of them to get the best value out of the healthcare, that can go a long way to alleviating some of the stresses, I think, that family doctors are feeling, family doctors in primary care are feeling, on top of the medical, that they're also have a lot of social things to deal with and don't really know where to take those.
Our emphasis has been to really kind of figure out how to build up that support for direct to the community and the patients and the caregivers. The idea of the self-care, the peer support, the preventative care, the informal care, the practical, like all of that stuff that happens outside of the primary care system. So they can have different conversations with their primary care provider and talk about specific goals of care, etc. At that level of primary care integration, primary care is used to working with a number of community resources and community networks. A number of them have volunteer capacity that could be trained in these kind of skills without requiring kind of new programs to be added into the mix. So that's kind of how we think there is a scalable way to support sustainable growth, leveraging those kind of programs and capacities that already exist, and looking at kind of those low cost ways to get the word out, and for people who are able to use tools and, you know, web-based e-health tools independently, to make that available to them. Again, all of this, which is around reducing that burden on the primary care practices, but really trying to bolster and complement the work that they're doing. So then the actual integration with primary care happens through kind of that referral to those volunteer services for people at that rising risk level, and then the fuller integration only around that small number of really complex situations, supporting the caregiver and the patient in those circumstances through the teams that are already there. But even some of those teams, like the palliative care home teams, they're used to incorporating volunteers into those team-based models. So that type of support, we think, would achieve the objectives of this model. And none of that requires really a lot of difference in the type of policy frameworks and, you know, structures that are already in place. It just requires a slightly different mindset and a slightly different approach to tools and listening to that patient voice and directing care around what's important to them.
So one last question here. Do you want to try to answer that question, Michelle? Has there been any collaboration with 211 Ontario for resource navigation with the work?
I can answer that.
Yes.
So yes, a lot of collaboration, and that kind of the 211 Ontario resource is the first line of navigation support. But of course, most of the resources in 211 direct you back to those formal services or funded services available in those communities. Then our volunteer training program says, now dig a little deeper and think a little bit creatively beyond the services and programs that are available in your community or virtually. What can the person do around self-care? What can the person do informally through, you know, joining a neighborhood-based local network? What could they do kind of maybe fitness is a goal? What could they do by inviting an isolated neighbor to go for a walk with them? Looking at other strategies beyond just access to those formal programs and building that into the navigation options. So that piece about not just signposting existing programs that you can find through directories like 211, and 211 is an incredibly valuable resource and we rely on it heavily, but trying to add that extra layer of creativity about not everything is a referral to another program, because some people don't want all of those kind of programs in their life, but they want these relationships, they want these activities, they want to feel like they connect and belong, and sometimes you get that through opening their mind to these other opportunities.
Yeah, this is an incredible opportunity to think more closely about primary informal caregiving and communities, something that's being built with patients' needs upfront and how this could work. So I want to really thank you for joining us and talking about this. And I think more to be continued as we continue to learn about how the systems could be integrated. And Deborah, I'll give you the last word.
Well, one tiny last point, and to also
Yeah.
think creatively about those people out there who have no caregivers, because we expect so much from the caregivers of people in these situations, and those people who don't have them in their lives really suffer and they have the worst outcomes. So that's why these mobilized communities are so important in these situations.
Mm-hmm.
One
Thank you.
final, it's just it's sorry, just a quick one. But we're talking about all the informal care and talking about it in big strides. It basically starts with one person recognizing that someone needs help and going from there. So it doesn't have to be whether it's informal or formal. Doesn't have to be some huge, okay, somewhat interventive step. Just start with talking to somebody, smiling to somebody, and then like just immediately their overall impact will be improved, and then just maybe they can carry it on throughout the day or whatever. It doesn't have to be a big step. Just start with something small and let it progress, and that in itself will keep people happy, less stress, less isolation, loneliness. So it doesn't have to be a big step. Just start small and let it work, and just supplement everything that happens.
Thanks, Chris. And thank you, Deborah. And thank you, Michelle. And I see that we have some comments in there. So I think, yeah, absolutely to be continued. And we'll be talking in the future. So thank you very much. And thank you all for coming to our learning session in 2025. And we'll see you at the next one, which will happen soon in February. Bye.
Thank
Thank
you.
you.
Thank you.